Good morning, everyone. I think we're still waiting for more people to join, but in the meantime, I think maybe we can begin to get started. I hope everyone can hear me okay. I'd like to welcome all of you to our Neonatal NIRS Consortium PAS Abstract webinar. My name is Valerie Chalk from Stanford University, and my co-moderators for today's session will be Jonathan Mincer from Mountainside Medical Center in New Jersey, and Zachary Vassilis from Washington University in St. Louis. Wanted to really take this opportunity to thank all of you for taking the time out to join today's session. If the last session was any indication, it would be a great experience. I'd also like to thank our presenters today. They are trainees from multiple institutions, and I'm really excited to hear about the work that they have done and to help to facilitate the discussion about NIRS monitoring. Now, before we get started, I did want to take this opportunity also to plug our Neonatal NIRS Consortium. We are a group that started about a year ago at PAS, and we plan to have yearly PAS meetings. Hopefully this will be in person in the future, but also for educational opportunities, we do host quarterly webinars where we talk about various topics related to either clinical or research use of NIRS in various settings, and we have speakers from multiple places. You don't have to be an expert in NIRS monitoring to be a part of this group. We have many people that are just starting out with using NIRS in their clinical setting or for research purposes. So we really welcome and encourage people to join our consortium. There's a listserv for communication among all members. And if you're interested in joining and haven't done so already, please send email to the Neonatal NIRS email address that you responded to get the registration for this event. Okay, so let's see. I think to start to transition, Zach, do you want to move it to the next slide? Everyone should be muted as they join, and we appreciate you continuing to keep your sound off as we allow the speakers time to talk. Any questions for the speakers, please enter it into the chat box, and the moderators will facilitate those questions at the end of each speaker's presentation. So here's our lineup for today. If everyone is ready, we are going to get started with our first presenter. This will be Luke Richard from the University of Wisconsin. He is a medical student, and we're very interested in hearing him talk about increase in preterm neonatal renal tissue oxygenation after caffeine administration. So let's put up his slides. And Luke, are you there?
Yep, can you hear me?
Perfect, yes.
Okay, great.
All right. Great, take it away.
All right, thank you. Hi, everyone. Just want to start by thanking the organizers for the invitation to speak today, and everyone for tuning in as well. I'm excited to share my research project with you. Next slide. So in the past 10 years, there's been an increase in research on acute kidney injury, or AKI, in preterm infants. The largest neonatal AKI study performed is the AWAKEN study, which is a 24 multi-center international trial that showed that overall, 30% of patients in the neonatal intensive care unit, or the NICU, develop AKI. In the figure on the left, you can see that they further analyzed patients according to gestational age. As you can see in the middle circle, 14% of infants are born less than 29 weeks gestational age. In the top right circle, they show that 48% of infants in this subgroup developed AKI, which is more than any other subgroup. This shows that the lower the gestational age, the higher the risk of AKI. This study also showed that AKI is a serious issue, and after adjusting for multiple confounding factors, AKI is associated with higher mortality and longer length of hospital stay. Next slide. Currently, AKI is defined by the neonatal modified K-DIGO guideline by an increase in serum creatinine and a decrease in urine output. Stage 1 AKI is defined by rising creatinine by 0.3 milligrams per deciliter. Stage 2 AKI is doubling of creatinine, and stage 3 is tripling of creatinine. Although these guidelines can reliably diagnose AKI, they're not ideal. This is primarily due to the delay in diagnosing AKI after an injury occurs. It takes about 24 to 48 hours for creatinine to rise and 12 to 24 hours for urine output to decrease. This delay in diagnosis prevents the development of new treatment and therapies for AKI. Next slide. One solution to this problem could be near-infrared spectroscopy, or NIRS. NIRS allows continuous, non-invasive bedside monitoring of regional tissue oxygenation. As you can see in the diagram to the right, near-infrared light travels from source to detector, passing through the microvasculature below. This measures oxy and deoxyhemoglobin in venous and arterial blood and results in sensitive, real-time measurement of blood oxygen remaining after extraction by tissues. In the diagram below, you can see how creatinine and urine output takes hours to detect decreased perfusion to the kidneys. This delay increases the risk of irreversible tissue damage. Our goal is to detect this change early when tissue damage is low, so we can develop treatment that prevents or reduces the severity of AKI. Next slide, please. One potential therapy is caffeine. Next point. Caffeine is a commonly used medication in the NICU to treat apnea of prematurity. A loading dose of 20 milligrams per kilogram is typically given within 6 hours after birth, and an 8 milligram per kilogram maintenance dose is given daily. Next point. In addition to the effect on the brain respiratory center, caffeine also acts as an alpha receptor antagonist in the kidneys. This causes vasodilation of the afferent arteriole and increased blood flow to the glomerulus, ultimately improving glomerular filtration and kidney function. Next point, please. Previous studies have associated caffeine exposure with decreased incidence of AKI. In a sub-analysis of the AWAKEN study, researchers found that only 3 preterm infants less than 28 weeks gestational age need to be treated with caffeine in order to prevent 1 case of AKI. Next point. However, the impact of caffeine on preterm infant renal tissue oxygenation measured by NIRS has not yet been studied. Next slide. We hypothesize that caffeine administration will increase renal regional tissue oxygenation in preterm neonates undergoing NIRS monitoring for detection of acute kidney injury. Next slide. Our prospective study was approved by the Meritor IRB. We included infants that were born less than 32 weeks gestational age and could have NIRS sensors applied before 48 hours of age. We excluded infants who had congenital anomalies of the kidney or urinary tract. After placement of sensors before 48 hours of age, they remained in place through 7 days of age. This allowed continuous monitoring of renal tissue oxygenation for several days. Next slide. So our goal was to compare renal tissue oxygenation before and after administration of caffeine. As you can see, the time of caffeine administration is denoted by T0. We calculated baseline renal tissue oxygenation by averaging values from 6 hours before each caffeine dose. We then compared this to hourly averages of tissue oxygenation for 6 hours after caffeine was administered to see how the values changed. We also analyzed IV caffeine doses 30 minutes after administration to assess the rapid effects of the fast-acting dose. Oral doses were not included in this 30-minute analysis. We used 2 methods to analyze the results. Method 1 includes a collective analysis of all subjects. Method 2 includes a subgroup analysis where we separately analyze infants according to their baseline renal tissue oxygenation. Next slide, please. Of the 29 subjects included in our analysis, the median gestational age was 28.4 weeks, and birth weight was 1,000 grams. The median of the average tissue oxygenation while sensors were in place was 59.76%, with an interquartile range of 43.43 to 68.99%. Next slide. We analyzed a total of 143 caffeine doses. 110 were IV and 33 were oral doses. During the first week of life, virtually all infants received one 8 milligram per kilogram dose of caffeine per day. Next slide. So first, we analyzed infants altogether. The x-axis shows time after caffeine administration, and the y-axis shows renal tissue oxygenation. The bar labeled pre-6-hour average is baseline renal tissue oxygenation. We did not see a significant difference in renal tissue oxygenation following caffeine administration in the collective analysis. Next slide. We then analyzed the change in renal tissue oxygenation following caffeine administration in the group with baseline values between 30 to 39.99%. This is the group with the lowest baseline renal tissue oxygenation values. Time after caffeine administration is once again on the x-axis, and renal tissue oxygenation on the y-axis. In this graph, we can see the changes in renal tissue oxygenation relative to the average baseline tissue oxygenation of this group, which is approximately 36%. We saw a significant increase in renal tissue oxygenation at 5 and 6 hours following caffeine administration. Next slide. Finally, we analyzed the change in renal tissue oxygenation following caffeine administration in the subgroup with baseline values between 40 to 49.99%. This is the group with the second lowest tissue oxygenation values. This graph is similar to the last, showing renal tissue oxygenation relative to an average baseline value of approximately 44%. Although no significant change was seen, we did observe an upward trend of tissue oxygenation following caffeine administration, which peaked at 4 hours post-dose. Next slide. Our main limitation in our study was the inability to capture loading doses of caffeine with the NIRS sensors. This dose is given shortly after the infants are born, before parents can be consented, and before sensors can be applied. We hypothesized that the large loading dose would result in significant renal tissue oxygenation changes. Next slide, please. And in conclusion, renal tissue oxygenation in patients with low baseline values below 50% increases following caffeine administration. These changes are time dependent and are most prominent 4 to 6 hours after caffeine is administered. We believe caffeine has the potential to be used as a therapy to increase renal tissue oxygenation in neonates with moderate to low baseline values, with hopes to treat or even prevent AKI. Next slide. Finally, I'd like to thank Dr. Matt Harrer for being an amazing mentor, helping me at every step of the way. I'd like to thank the Shapiro program for this opportunity, and of course, the patients and families for participating in the study. In addition, thank you to Unity Point Health Meritor Foundation for funding, and UW-SMPH and the Department of Pediatrics. Next slide. All right, thanks for your attention. I take any questions.
Thanks very much. That was a great presentation. I think that the use of NIRS for renal tissue, for monitoring renal tissue oxygenation is really quite a growing field. And congrats to you and your mentor, Dr. Harrer, for advancing that area. I'm going to start us off with a few questions, and please, audience, please type in your questions into the chat box as well. Can you tell us a little bit, so caffeine has a relatively long half-life. Were you able to observe if these increases in the renal saturation were sustained beyond the 4 to 6 hour period of monitoring?
We did have the monitors on continuously, so the data was captured beyond that 6 hour period. But we didn't necessarily analyze the data beyond that 6-hour period.
Mhm.
But that would be
Yeah,
something that would be interesting to look into.
yeah, for sure. And then what about what other kind of clinical markers or outcomes have you thought about exploring next to kind of correspond with this increase in renal saturation measures that you found? I'm just thinking things like
Um,
urine output, or what are some things that you think would be interesting to
mhm.
explore?
Yeah, that's a good question. So I know one thing that goes along with the serum creatinine increase and decrease in urine output is just the incidence of AKI in general. So we're kind of trying to correlate the number of AKIs that occur with the renal oxygenation as well. So maybe that's a marker as well.
Yeah, yeah, perfect. And I really think that's what the power of monitoring renal sats is. It's really, excuse me, it's such an early marker before sometimes even you're seeing any changes in urine output or creatinine. So I think that's really going to be something to further investigate, especially in our preemie population. Um,
Uh-huh.
Another question I had is, do you have any sense of how cerebral saturation also changed? I think a lot of us here have been so focused on looking at the brain, and caffeine's protection, neuroprotection properties as well. So I'm curious if you've seen any related changes in the cerebral sats.
hmm Um, Not something that we necessarily analyzed with the data, although we did have that data. We monitored both cerebral and renal saturations while the caffeine was given during that 7-day period. Um, so although I didn't look at it necessarily, just with my experience of keeping an eye on the monitors every day, uh, it didn't seem to fluctuate quite as much as the renal saturations. So it seemed to stay relatively high during that period. So maybe not having quite as much of a effect, caffeine not having as much of an effect on the brain as the kidney.
Yeah, and I see Zach is also saying looking at a simultaneous cerebral to renal oxygenation ratio might be helpful if you have that data just to kind of get an idea of the kind of differential perfusion of both organs. So that's something you could explore in the future with your data set.
Okay, yeah, that's really helpful. It's convenient to have that massive spreadsheet of data
Yeah,
that you
I can
can
imagine.
mess around with.
And then the last question I had was, did you see any difference with oral versus IV dosing of the caffeine? And your numbers may be too small to really tease that out.
Yeah, nothing that I or recognized, and nothing that we really looked into as well.
Yeah, that's
So sorry about that.
interesting to think about. Um,
Yeah.
yeah, and I think Jonathan, I think you have some additional questions, and there's a couple other questions in the chat box.
Yes. First of all, Luke, thank you for giving an excellent presentation. You're very familiar with your subject and describing a very sophisticated study at the same time. So very nice job on that. First, one of the questions from the chat box regards keeping the renal sensors on for 7 days. Did you do unilateral or bilateral monitoring?
We did unilateral monitoring.
Okay. Any concerns regarding the skin? Were those sensors ever moved over time for skin inspection underneath?
They were removed for skin inspection, but we also had I believe it's called Mepitel.
Nepotel, yes.
Gel. Yeah, we had that gel underneath the sensors as well. And I believe the company that Invos it is that releases the sensors, they've done studies that show that there's no effect on the sensor's ability to measure oxygen with the gel underneath. So that did a really good job. And we inspected the skin. No patients in the study had any skin breakdown.
That is correct, that the Mepitel does not affect signal integrity. Regarding placement of the renal sensors, were you doing this based on landmarks or was there ultrasound guidance? How were we sure that we were monitoring the kidney? Any thoughts on that?
That was actually one of the most difficult parts of it, is making sure that we got the sensor in the right place. So we mostly did it by landmarks and kind of trying to feel in the area that we thought that the kidneys would be. There was some data that was pretty choppy, and we thought that there was issues with the monitoring. So that was an issue that we had. And I think that you mentioned the ultrasound guidance is something that we were possibly hoping to do in the future.
Sure. Another question that arises from the chat box as well, and also my own, but I noticed you chose an hourly data sampling interval for your renal data. Now, there's been previous studies that look at the variability of the renal signal that shows up to 15 to 20% variability at baseline for the renal site. I wonder if it would be possible to reanalyze some of your data in shorter segments to maybe to remove artifacts. In your observation, was the renal signal quite variable, or was it mostly stable numbers?
It was pretty variable, and that was something that we had some issues with as well. We were looking into how we could possibly get rid of data that is so variable that it possibly artifact or something like that, but we didn't go into erasing any of that data in this analysis.
Sure. I'm sure as you collect more data and maybe take a closer look at the numbers, you'll be able to do that over time. One last question from me. This patient population that you're working with runs the whole gamut of overall disease severity. For your data set, do you have information on which of these babies had other potentially confounding conditions, large PDA, anemia, hypoxemia, severe respiratory problems, sepsis, etc., to help sub-analyze your data in one way or another? It's very hard to lump this group of patients together.
Yeah, we have collected a lot of that data, and it's kind of still in the process as well to find out all that information, both about the infants and then also some maternal factors that we're taking into account.
Very well. I invite any other questions from the audience in the chat box. Luke, I'd like to again commend you on an excellent presentation. You're very familiar with your subject, and that was very impressive.
Thank you.
Any other questions in the chat box?
This is Dr. Hare at University of Wisconsin. I just want to commend Luke on doing a great job this summer and really doing a really nice job of presenting our data. He did a great job of answering all the questions, and really the goal of doing our hourly average of the renal NIRS was try to remove some of that variability and some of that artifact. But I think it's a really interesting idea to potentially look at it in different intervals of every 15 minutes or even smaller type of intervals like that as well. And then we certainly are going to look into the other conditions and try and publish some data about the acute kidney injury relating to the renal tissue oxygenation, hopefully here soon.
Excellent.
Thanks, Matt.
Okay, great. I think, Jonathan, you're going to introduce our next speaker.
Yes, for our next presentation, we have, and I'm hoping I'm pronouncing correctly, Eniko Zakmar from the Harvard Medical School from Brigham and Women's Hospital, who will be presenting on cerebral oxygen saturation as an indicator of brain injury in neonates receiving therapeutic hypothermia for neonatal encephalopathy. You may begin.
Hi, can you hear me? Hi.
Yes,
hello.
we can.
Yeah, okay, great. And do you see my screen?
Yes,
yeah.
we do.
Okay, thank you. So thank you for this great opportunity, and thank you for having me here today. In the next few minutes, I would like to talk about the cerebral oxygen saturation as an indicator of brain injury in neonates receiving hypothermia for neonatal encephalopathy. So I have nothing relevant to disclose. So the continuous monitoring of cerebral oxygen saturation may contribute to the improved neurocritical care of infants treated with hypothermia for neonatal encephalopathy. Severe brain injury may be associated with increased cerebral blood flow and reduced oxygen extraction, and thereby resulting in a higher cerebral oxygen saturation. Many studies have reported an association between the higher cerebral oxygen saturation and adverse neurodevelopmental outcome. However, not all studies of the cerebral oxygenation and its relation to the brain injury have been consistent. So the uncertainty about the evidence for the clinical utility of NIRS has led to its limited clinical use of NIRS in the NICU. So NIRS has been adopted for clinical use as the part of the neurocritical care program at Brigham. And the aim of this retrospective study was first to assess the differences in the cerebral oxygen saturation throughout the phases of hypothermia in neonates receiving hypothermia for neonatal encephalopathy, and second, to evaluate the association between the cerebral oxygen saturation changes and brain injury detected on the post-rewarming MRI. So between January 2018 and May 2019, 64 patients received hypothermia. Of those, 53 patients has NIRS data. We excluded 4 patients due to the brief period of recording. So altogether, 49 infants were included in the analysis. We identified 2 groups of patients based on the post-rewarming MRI. In the first group, infants had a normal MRI scan without any signs of injury, with the exception of subdural hemorrhage. And in the second group, the infants presented with brain injury. And the pattern of the injury was evaluated according to a novel MRI grading system developed by Vicky et al. So the neonatal sensor was placed on the frontoparietal side of the infant's head and alternated between the right and left every 6 hours. So the left and the right-sided measurements were treated equally in our analysis. We categorized the nearest measurements into phases based on the days of cooling and rewarming. The phase 1, 2, 3 correspond to the first, second, and third day of hypothermia. The phase 4 was the period of the rewarming, and the phase 5 is the time after the rewarming. Statistical wise, we built a multivariable regression model to assess the predictive value of cerebral oxygen saturation for the brain injury. So the demographic and the clinical data were comparable between the 2 groups, but we need to highlight that the infants with brain injury had a severe metabolic acidosis with a lower postnatal pH, a higher pace deficit, and a higher lactate. Additionally, also the incidence of the electrical seizure was higher in the infants with brain injury. However, the EEG pattern didn't differ between the 2 groups within the first 24 hours of life and at the time of rewarming. I also need to mention that you can see here that a high number of patients with mild encephalopathy were included in this analysis. The MR studies were carried out after rewarming at a median age of 4 days of life, and the brain injury was detected in the form of white matter and cortical injury and gray matter injury. So this graph shows the cerebral oxygen saturation changes throughout the phases of hypothermia. The green line represents the infants with brain injury, whereas the blue one represents the infants with normal MRI. First, a one-way repeated measurement ANOVA was used to determine if there was a differences in the cerebral oxygen saturation throughout the 5 phases in each group. And the ANOVA revealed that the cerebral oxygen saturation increased from the first day to the second day of hypothermia in infants with brain injury. However, it remained stable over the time in infants with normal MRI. And second, the 2 groups were compared in each phase, and infants with brain injury had a higher cerebral oxygen saturation at the time of rewarming. Since the cerebral oxygen saturation was higher at the time of rewarming, a logistic regression model was built to see the predictive value of cerebral oxygen saturation in phase 4, so at the time of rewarming. And this model showed that a higher postnatal base deficit and an increasing cerebral oxygen saturation at the time of rewarming were associated with an increased odds ratio of brain injury. And this association remained significant even after controlling for clinically relevant parameters such as postnatal base deficit, 5 minutes Apgar score, the stage of encephalopathy, and the pattern of EEG at the time of rewarming. And as a last step, we analyzed the subgroup of patients with gray matter involvement. And what we see is that the infants with gray matter injury had a higher cerebral oxygen saturation on the second day of the hypothermia, and also at the time of rewarming compared to the infants without gray matter injury. And this regression modeling showed that the increasing cerebral oxygen saturation at the time of rewarming was associated with an increased odds ratio of gray matter injury after adjusting for the same clinical parameters as I mentioned on the previous slides. So to sum up, the infants with brain injury had a higher cerebral oxygen saturation throughout the phases of hypothermia compared to the infants without any brain injury, and this difference reached a statistically significant level at the time of rewarming. In addition, the cerebral oxygen saturation increased significantly from the first to the second day of hypothermia in infants with brain injury. However, it remains stable in patients with normal MRI. The explanation behind the second point could be that the increased cerebral oxygen saturation in infants with hypoxic ischemic injury may reflect the combination of the higher cerebral blood flow and the decreased extraction of the oxygen associated with the neuronal cell death due to the secondary energy failure. And more importantly, the mean cerebral oxygen saturation at the time of rewarming was an independent indicator of brain injury, especially for the presence of gray matter injury. So thank you for your kind attention, and please feel free to ask.
Very well. Thank you for an excellent and very interesting presentation regarding the use of cerebral NIRS and in the context of HIE. I have one question regarding the actual practice of monitoring at the bedside. When you look at the differences between, and although they are more pronounced for a deep gray matter injury, the differences between groups for overall brain injury are very small. I think if you look at drew a line, it's like 80 versus 85, with a lot of overlap at the different time points, as shown in the error bars there. Although these changes were statistically different, especially during rewarming in phase 4, does this have implications for the actual use of the monitor at the bedside? Like, is this something that a clinician could actually see?
So thank you for your question. Like it's very hard to answer, but I think the answer is yes, because infants with very severe brain injury may have a vasoparalysis, and in that case, the cerebral oxygen saturation could be very high, even around 90-95%, and you can see no variability in the data. So yes, I think you can identify the severely affected infants.
Okay, very well.
Using NIRS. Yeah.
Another question related to that has to do with the stability of the cerebral signal in general. There's been plenty of research to show that the cerebral signal is fairly reliable, and from within the same patient over time, it is quite a stable signal. Was there any noted changes in the baseline variability of the NIRS signal between babies who were not showing brain injury and ones who were showing any degree of severity of brain injury?
So yeah, as you said, it's a stable signal, but one of the most difficult point of the analysis was to remove the artifact. So we removed which was higher or lower than the 4 standard deviation of the mean. It's not a perfect method to see the artifact, but since it was a retrospective and not a prospective data analysis, it's very hard to identify or to see the signal quality.
I agree. Removal of artifacts is definitely something that has to be worked on over time. And I wonder, even with artifacts removed, whether the variability of the signals would show difference between the two groups of brain injury and no brain injury. One of the questions coming from our chat box, and I'd like to invite others to please ask questions if anything comes up. What happened to the cerebral saturation values during seizures in the infants with brain injury, if any were noted?
Yeah, it's a good question, but unfortunately we didn't look into these data, and as I showed on these slides, so only a few patients presented actually with the electrical seizure, but we didn't analyze this period in details. So based on this analysis, I couldn't answer this question because, yeah, we didn't analyze.
Very well. Maybe something interesting to look at.
Yeah.
I'd like to turn over the Q&A to Zach.
Hi, thanks. That was a great presentation. I really enjoyed hearing your data. I had a couple of questions. So one, on your graph where you show the difference in saturations between your two injury groups, I noticed just in general, these cerebral saturations are pretty high, particularly for an INVOS device, which tends to run a little bit on the lower side. I was wondering if you had any comment on that in general, and then maybe more specifically, if you also looked at FTOE during this time period to see if this was a impaired extraction for the reason for the high sats.
So yeah, we didn't look into the fractional tissue oxygenation, and the reason for that is a technical reason, because the oxygen saturation was recorded hourly in the electronic health system, and the NIRS device and the bedside monitor were not time synchronized, and the NIRS device has a higher sampling rate, like two per minute. So that's why it's a technical limitation of the data, but it's absolutely, I agree with you, it could improve the data. And yes, you can see on the graph a relative higher saturation. So as we know from the literature, the normal cerebral oxygen saturation is between 50 and 80%, but mainly it was recorded with adult sensors and not with neonatal sensors. So it could be a possible explanation that we use the neonatal sensor.
Okay, yeah, great. That sounds good. So I'd like to, I have one more question, but before I answer, I just want to invite, if anybody has any other questions, to please enter them into the chat box. I was wondering about your comparison with deep nuclear gray matter. So the depth of light penetration in a NIRS device is not deep enough to get down into the deep nuclear gray matter. So you're not directly measuring that. But I was just wondering, do you think there's a correlation between deep nuclear injury and the subcortical white matter and cortical gray matter that the NIRS device is actually picking up?
So yeah, so it's well known that the gray matter has the highest rate of cerebral blood flow and cerebral metabolic rate, even in the normal brain. And in infants with hypoxic ischemic injury, a higher global cerebral blood flow can be largely attributed to the marked increase in the regional cerebral blood flow to the gray matter. And also, I think there is an association between the brain injury and the involvement of the gray matter.
Okay, and then there's one, I think there's a great question from the chat. you guys moved the probe from side to side, presumably for skin integrity reasons. Did you notice, was there a difference in saturations when you moved from left to right side? And sort of, not in the question, but sort of a related one, if for babies that had unilateral injury on MRI, was there a link there?
Yeah, it's a great question, and it's another limitation that the left and the right sided measurements were treated equally in our analysis, so we didn't make difference between the right and the left sided measurements, but the infants in the analysis didn't have like a great stroke or a stroke or an IVH. So yeah, but it would be interesting to see if there is a difference between the left and the right sided measurements.
Right, great, thank you. So we are going to do a short intermission here before we do our last presentation. Let me share my screen, and then we'll get Valerie back here.
Great. Zach, do you want to run the poll since you did a great job putting it
Sure.
together?
Sure. So as Dr. Chalk mentioned earlier, if you guys are interested in joining our mailing list to hear more about these sessions, we also have gotten questions about recordings of these sessions, so that will be available, and we'll send that out on the listserv. So just go ahead and send an email to the address on the screen, and we'll get you signed up. So we have 2 polls today. For those of you that joined us last time, we've added an additional question. But the first one is, what would you guys be interested in hearing about for our next webinar? So this is not that we won't cover all of these topics at some point, but which one would you like to hear about next? So if you go ahead and answer the question that should be on your screen there, we'll give I don't know, about 90 seconds or so for people to answer. And we'll combine this with the results from our first session to come up with the overall winner. We'll maybe give it another 20 or 30 seconds for those of you who haven't quite answered yet to put in your vote. All right, I'm going to go ahead and end the poll. Looks like NIRS and NEC and NIRS and the PDA tied in this poll. So that's fun. That's a little bit different than the last time. Let me switch to poll number 2. So the second question, many of you have joined us for both sessions, some for one each, and we've had a great response. We are wondering if you guys would be interested in more presentations like this, other abstracts from PAS or other conferences, perhaps original ones. So we'll give this a few seconds for people to go ahead and answer as well. All right, just another 15 seconds here. All right, well, I think it is safe to say that the overwhelming majority of you guys would like more sessions like this. So we will put our heads together and figure out how to make that happen. So please sign up for our listserv so that you can hear about these presentations. That will be the main place where we'll send out information about when, where, and how to see those next talks. So I think we are ready to go to our final presenter now. Back to you, Valerie.
Great. Well, we are really pleased to welcome Aisling Garvey from University College Cork, who will be speaking about early cerebral NIRS in hypoxic ischemic encephalopathy. So welcome.
Hi, thanks very much. Good morning. My name is Aisling Garvey and I'm a neonatal research fellow with the Infant Centre in Cork in Ireland. Thank you for giving me the opportunity to present this research on early NIRS in hypoxic ischemic encephalopathy. I have no conflict of interest to disclose, and this work was funded by a research fellowship grant from the National Children's Research Centre in Ireland. So hypoxic ischemic encephalopathy is the leading cause of acquired brain injury in term infants and is one of the leading causes of disease burden worldwide. It accounts for 25% of all term deaths. And when we look at the leading causes of premature mortality worldwide, you can see that neonatal encephalopathy is 6th on the list, ahead of AIDS, diabetes, and all types of cancer. Therapeutic hypothermia, initiated within 6 hours of birth, has revolutionized how we treat infants with moderate and severe HIE. Yet despite this, 40% of infants with HIE still have neurological difficulties at 18 to 24 months, and more subtle learning and behavioral difficulties later on. Infants with mild HIE are a largely understudied population, and at present they lie outside criteria for therapeutic intervention. They were excluded from the therapeutic hypothermia trials due to their perceived low risk of disability. However, recent studies have highlighted significant levels of disability at follow-up. We know that cerebral NIRS provides an important window into the cerebral hemodynamic status of the neonate, and studies have suggested a correlation between the severity of the brain injury, neurodevelopmental outcome, and changes in cerebral oxygenation in infants with HIE. Higher cerebral SO2 and lower FTOE values, particularly beyond 24 hours of life, have been associated with MRI injury and poor neurodevelopmental outcome. And this is likely due to a combination of increased cerebral perfusion and decreased utilization of oxygen, which may correlate with the secondary energy failure in HIE. Few studies have examined the ability of early NIRS, and by this we mean before 6 hours of life, to predict outcome, and only one study included infants with mild HIE. So the aim of this study was to document early CSO2 values in all grades of HIE, and to describe the evolution of these values over the first 36 hours of life. So this was a prospective observational study conducted in Cork University Maternity Hospital in Ireland, and our centre is a tertiary neonatal centre with an annual delivery rate of about 8,000 deliveries per year. And we service a large hinterland in the south of the country and receive referrals for therapeutic hypothermia. So we included infants 36 weeks gestation and above with clinical and biochemical evidence of HIE. And we excluded infants with congenital abnormalities, inborn errors of metabolism, congenital infections, or confirmed sepsis. And infants were graded based on assessment with a modified Sarnet score at 1 hour of life. And in our centre, therapeutic hypothermia is provided to infants with moderate or severe HIE. So infants with mild HIE were not cooled. NIRS monitoring was commenced as soon as possible after delivery, following parental consent, and we used the in-vas oximeter with the neonatal probe. Median CSO2 values were calculated at 6, 9, 12, 18, 24, and 36 hours of life, and a mixed model analysis was used to investigate how CSO2 changed over time for each grade of HIE. So there were 58 infants included in this study. 28 were mild, 24 moderate, and 6 were severe. As you can see, infants were of similar gestational age and birth weight, and approximately 1/3 of infants in the mild and moderate groups were born by caesarean section. By 5 minutes of life, 11% of infants in the mild group had an APGAR score of less than 5, compared with 50% of infants in the moderate group and 100% of infants in the severe group. 50% of the infants in the mild group required positive pressure ventilation only after delivery. But as you would expect, infants in the moderate and severe groups required more extensive resuscitation measures. At 6 hours of life, our mean NIRS values were highest in the mild group and lowest in the moderate group, and this difference was significant. And when we looked at changes in values over time, the best fitting model included a fixed quadratic time effect for each group and a random linear time effect. Infants with mild HIE, shown here with the green line, had the highest NIRS value at 6 hours of life, and values increased slowly over the first 24 hours and then plateau. Infants with moderate HIE treated with hypothermia are shown by the blue lines, and they have the lowest CSO2 values at 6 hours, but the greatest rate of increase over the first 24 hours of life. And by 36 hours, they are on par with their uncooled mild counterparts. The red line represents infants with severe HIE, and this group increase almost linearly over the first 36 hours of life and overshoot both the mild and the moderate groups. And this is the first study describing the early evolution of NIRS in all grades of HIE. And it's interesting to note that the moderate group are initially the lowest, but they're then on par with the uncool milds. And the severe group are lower initially, but values increase in a linear fashion. And the patterns we see may be explained by a number of reasons. Firstly, therapeutic hypothermia aims to reduce cerebral metabolism and thus decrease oxygen consumption. It also has an effect on circulation and may result in decreased oxygen delivery to the brain. The severity of the underlying encephalopathy also has a role to play. And previous studies have described altered hemodynamic control in HIE, which leads to hypoperfusion on day 1, followed by hyperperfusion on days 2 to 3. An earlier hyperperfusion is associated with increased risk of brain injury. And the increasing severity of encephalopathy may also result in reduced consumption due to neuronal injury. Sedation is routinely used in our centre for infants undergoing therapeutic hypothermia, and the use of sedation may result in reduced oxygen consumption and, as a result, higher CSO2 values. And of course, ventilation, including oxygen administration and partial pressure of CO2, can also influence CSO2 values. So to examine these results further, we are currently in the process of assessing FTOE in these infants, which will provide us with more information regarding organ utilisation. And we also plan to correlate these findings with both short and long-term measures of outcome to determine whether early cerebral NIRS would be an important predictor of outcome. I'd like to thank my supervisors as well as my team at the Infant Centre, the NCRC for funding this work, and most importantly to the infants and families included in the study. I'd be happy to answer any questions you may have. Thank you.
Thank you very much, Aisling. That was a very interesting study. I think this is an area, especially as we're trying to figure out this category of babies with mild HIE and whether or not they should be cooled. I think the use of NIRS in this population is going to be critical in helping us to inform that as well. I'm going to start us off with a few questions. I'm just kind of curious if you could elaborate a little bit more. If these babies with mild HIE were not cooled, how much do you think that difference in cerebral saturation between that mild HIE group and the more moderate or severe babies was affected by the cooling process itself versus the degree of injury?
Yeah, and I mean, I think that's the $1 million question, and it's really interesting. And I'm hoping that the FTOE analysis will help us to answer that a bit better. It's hard to know whether there's some element of hyperperfusion and decreased uptake in the milds that maybe aren't protected by the hypothermia because they're uncooled, or whether it's reduced cerebral blood flow in the moderate group. And I think it's hard to answer that question with just the CSO2 values alone. So I'm really hoping that the FTOE values might give us a bit of an indication or a clue as to I suppose trying to differentiate between the severity of the encephalopathy or the hypothermia itself. But it's really interesting, and I think it's a really important question to be answered.
Yeah, and if you can maybe put up your graph of looking at the trajectory of the cerebral NIRS values.
Sure.
I think it's interesting because you know, we've been with some of the earlier literature, a lot of the cerebral NIRS predictive ability for adverse outcomes, at least in the moderate to severe HIE group is typically like the 12 to 24 hour age range, which people are thinking is possibly due to secondary energy failure and poor extraction from neuronal injury. But it's interesting that looking at that, your mild group of babies, their cerebral sats are higher earlier. I don't know if you have any, theory for why the trajectory is a little bit different, or if that could be predictive at all in an earlier time period.
Yeah, and I mean I suppose that would be the idea. We know the hypothermia works better when it's commenced before 6 hours, and it can be really difficult when clinical examination is so subjective to even differentiate between the mild and the moderate groups. And if you had something objective like a NIRS value that could maybe stratify them or give you an indication as to which babies were in particular grades, and more so which babies, if you had an early value, would predict outcome based on both MRI or, more importantly, I suppose, long-term outcome. And we have that data, and neurodevelopmental outcome is underway at the moment. So we're hoping to correlate those early values with outcome, and see if we can pick out maybe which of maybe even the more severe mild to moderate group are at risk of brain injury or neurodevelopmental issues later on.
Yeah, we're really looking forward to some of that long-term outcome data from you. Maybe I will turn it over to Jonathan at this point to get to a few additional questions.
Sure. Thanks for a very interesting presentation. It's amazing to see that there's already some distinction between the mild, moderate, and severe groups when they're looked at very early on. Would it be beneficial to your study to include a control group with no HIE as a comparison in order to be compared, or in order to be looked at over the same time interval as the babies in your study?
Yeah, that would be really interesting, because it would help to differentiate as well whether it's the cooling or the encephalopathy between the mild and the moderates. I suppose the difficulty is obtaining continuous measurements on normal babies for such a long duration of time. These babies were in the unit and they had other monitoring undergoing, so it was easy to obtain the NIRS values, whereas it might just be practically difficult to get continuous NIRS values from control babies on the postnatal ward. But I mean, I think it's definitely a piece that's missing from this, and would provide a lot of useful information.
Another question that came up is, looking at this data, there's definitely a difference between the patterns of moderate and severe over time compared to the mild group. If I just wonder, for a clinician standing at the bedside, if they've already made a clinical diagnosis of a mild HIE, but then notice over time that the baby is behaving like a moderate, or even worse, like a severe, do you feel, where would the leap of faith be that we would use information like this in order to change our management?
Yeah, I think there's a lot of research done in NIRS and HIE, but I suppose the difficulty with it, and to make it, I suppose, universally accepted into neonatal care, is that there's so much difference in methodology in the devices used, the probes used, and even the locations of the NIRS probes used. So I think we need more research with bigger numbers and more standardized methodology before we could definitively say, if you've got a baby whose NIRS is increasing in this trajectory, that maybe you should consider changing your management. But I think it's an interesting thing to keep an eye on and watch. It might just give you a clue to the babies who perhaps need more close observation following.
It's like those first few hours are quite critical, so gathering whatever information could be most helpful to our decision making is key. Mm-hmm. Another question that came up in the chat box, and which we noticed as well, the severe group's pH compared to the mild and moderate was different. Mm-hmm. Any comments on that?
So the severe group, the pH, it was more in line with the moderate groups. Now that was just the arterial pH, and we do have values for a first postnatal pH and first lactate, which is slightly different, and I suppose we need to look at that in more detail and see might be interesting whether we pick the lowest of the pHs that we get or which one is most predictive of greater outcome.
So the severe group was treated as severe, even though the pH looked better than the moderate group.
Yeah,
So,
because it was based, their grading was based on their clinical examination, so they had clinical features of severe encephalopathy.
sure. I'd like to invite the audience for any further questions in the chat box. All right. And with that, I think we've completed. Thank you again for an excellent presentation.
Thank you very much.
I'll turn it back over to Valerie.
Okay, great. Well, really just wanted to take this opportunity again to thank all of our speakers for putting together some great presentations, and to encourage all of you who've attended, if you haven't done so already, to join our NIRS Consortium and our mailing list so that we can inform you of future programming opportunities with NIRS-related subjects. So thank you again, everyone, and we'll hope to see you again in your future.
Thank you.